Okay, good morning, everybody. Let's just go on 7 o'clock. So time for our Friday Grand Round session. This morning, we're hoping to have two presentations. First up this morning is Dr. Schwartz. Zack, he's one of our R2 residents, Edmonton born and bred. He's currently on rotation at the Sturgeon, and he's going to talk to us about leadless pacemakers. And following that, if we manage to get the logistics correct, then we have a medical student with us who's hoping to tell us about the project that she's been working on. So without further ado, I'll hand over to Zack. Thank you.
Can everyone on Zoom hear me? Perfect. So yeah, I just wanted to, if I can figure this Zoom out. Yeah, my name is Zack. I'm one of the R2s here.
Just that one there, that's it. Yeah.
Perfect. Yeah, I just wanted to talk about Leadless Pacemakers. Thanks for letting me take up part of your morning. There's a lot to go through, so we'll try to rush through parts of it and then spend more time on kind of the new stuff. This topic was kind of inspired by a question I received after my resident presentation just on cardiac implantable devices in general. I was asked about leadless pacemakers. I knew nothing about them, so this is kind of a part two to that. I just want to thank Dr. Lamb and Dr. Quadros for their huge help and advice on this presentation. I reached out pretty last minute, and they were both very, very willing to sacrifice time to make this happen. So, huge thank you to them. No conflicts of interest. In terms of objectives, so we'll start by quickly reviewing pacemakers and ICDs. Then we'll dive into leadless pacemakers specifically, kind of compare them to conventional or traditional pacemakers. And then we'll talk about a little bit about the future of automated pacing and talk about subcutaneous ICDs and leadless CRT devices. This is kind of just what I mentioned in terms of our outline. Very, very quickly, we're just going to talk about the history of cardiac implantable electronic devices. So there's a lot here. I won't go into all of it, but I just want to highlight that in 1958, the very first implantable pacemaker was implanted. And since then, for the last 60 years or so, not much has changed significantly. We still have the same design of a generator with leads that travel through the subclavian into the heart and stimulate electrical activity. But in 2012, we had the implantation of the first leadless pacemaker, and in 2016, those leadless pacemakers were first approved by Health Canada. So that's kind of when everything changed and where we changed something that had been working fairly well for 60 years, but had significant drawbacks, as we'll get into. In terms of numbers, so there are over 250,000 Canadians living with pacemakers. A very small minority of those have leadless pacemakers, less than 5%. And every year in Canada, there's about 25,000 pacemakers implanted. Globally, there have been about 300,000 plus leadless pacemakers implanted. It's hard to get a number for Canada, but again, less than 5%. But that number will continue to grow. So in terms of conventional pacemakers, I just want to really, really quickly go over this just so that we're all kind of on the same page, because that is kind of essential to understanding leadless pacemakers as a whole. So conventional pacemakers, just starting on the left of this graph, they are indicated for bradyarrhythmias, mainly from sinus node dysfunction, high-grade AV block, and their function is to sense that the heart is at an inadequate rate and then pace at an adequate rate. Most of them also have rate modulation, so that means that they will sense some kind of physiologic change in the body, whether that's an increase in temperature or ventilation, and they will interpret that as increased energy need or metabolic demand, and will increase their rate in response to that. So obviously pacemakers have pacing ability. Some, but not all, will have ICD function. So not all pacemakers can defibrillate. And then typically a pacemaker with magnet placement will turn it into an asynchronous mode where it's no longer sensing, it is just pacing at a set rate. ICDs are indicated for the prevention of VTAC or defib. They function by detecting the rhythm and rate, and they will either defibrillate if that's appropriate, or if possible, especially for VTAC, they will do what's called anti-tachycardia pacing, which is where they pace at a rate faster than the VTAC to try to put the heart in a refractory period so that it breaks the VTAC. And then by that, they're able to avoid shocking the patient. All ICDs can pace, or all conventional ICDs can pace. And then the magnet response is that it inhibits the anti-tachyarrhythmia therapies, but it does not inhibit, or it does not put the ICD into an asynchronous pacing mode. So to do that, you have to reprogram. CRTs come in kind of two flavors, the CRT-P or CRT-D. The P is for pacemaker, the D is for defibrillator. So if it's just a CRT-P, there's no ICD function, whereas CRT-Ds will have the anti-tachyarrhythmia function. They're indicated for heart failure with a reduced ejection fraction and a conduction delay. And basically their function is to promote synchronized contraction to improve the EF. They also obviously pace, and if they have the CRT-D ICD function, they will have a defibrillation function. The magnet response is a little bit more complicated, so I won't get into that. The guidelines are kind of to contact your EP service for CRT devices if there's risk of electromagnetic interference. Chest X-rays can be very helpful for us in anesthesia, especially for patients that come in overnight. They're unresponsive, they're going for emergent surgery. There's no time to significantly investigate. On the left, so you see a generator kind of in the left upper thorax with leads that go one to the right atrium, one to the left. One to the right atrium, one to the right ventricle. There's no shocking coils on the leads, so you know this is a pacemaker, no ICD function, so it cannot shock. In the middle image, you can see a single lead, and there are these shocking coils that the yellow arrows are pointing to. So this is an ICD, it's a single chamber ICD. And then on the right, again, we see the shocking coils on the leads. There are 3 leads, so this is a CRT device. One goes to the right ventricle, one to the right atrium, and then one goes to the coronary sinus. That's what the orange arrows are pointing to, and that's one of the ways that we pace the left ventricle. So this is a CRT with ICD function. This is the secret code for pacemakers, not so secret code. Again, I don't want to get into this too much, but position 1 is pacing, which chambers are paced. Position 2, which chambers are sensed. The third is rate modulation, or sorry, the response to sensing. And the fourth is rate modulation. The fifth position is more so academic. It's, yeah, I won't get into that here, but in terms of the perioperative management of pacemakers, so the main concerns intraoperatively would be with electromagnetic interference, or EMI, and that is from inappropriately interpreting monopolar cautery. So for pacemakers, they sense the EMI as electrical activity in the heart, so they think the heart's pacing as it should be, and so the pacemaker will inhibit its pacing. It'll inhibit itself. And so that can result in significant bradycardia or an arrest. So a magnet will put the pacemaker into asynchronous mode. And then for ICDs, they can detect EMI as VTAC or VFib and shock the heart. So both very bad. And that's kind of the main intraoperative concern. This is for Miller's. So this is the algorithm just in general for CIEDs. So if there's a risk of EMI, which they've kind of defined the umbilicus as the cutoff point for monopolar cautery above the umbilicus, then there's a risk of EMI. And basically, if the patient has a pacemaker and is pacemaker dependent, they should have reprogramming or a magnet. And if they have an ICD, they should have reprogramming or magnet. If they have an ICD and they're pacemaker dependent, they should be reprogrammed to asynchronous mode because the magnet will not have that function in an ICD. The other highlight is that a magnet and external pacing and defibrillation should always be available for these patients, regardless of EMI risk. It's best to kind of split the complications of conventional CIEDs into acute or those that occur during implantation or very shortly after, versus kind of the chronic complications. So the acute things would be pocket hematoma, hemo or pneumothorax, lead dislodgement, cardiac perforation, pericardial fusion, tamponade. And then the more chronic things would be lead failures, skin erosion, pocket infection, or other very serious infections. Central venous occlusions, so those leads in the wires in the central veins can cause stenosis and even occlusion. Tricuspid valve injury, especially for wires that cross the tricuspid, and then pacing-induced cardiomyopathy. So looking at this list, you can see that a lot of these complications are related to the leads themselves or to the pocket generator. So finally, we get to talk about leadless pacemakers. So this is kind of the meat of the presentation. Leadless pacemakers were designed to avoid those complications that we kind of went through. They're designed as a single unit about the size of a AAA battery, like one cc. They contain everything: the generator, the circuitry, the electrode, and they're implanted into the myocardium, become endothelialized, and they're capable of pacing, sensing, and rate modulation. They do have their limits. So they currently, there are no leadless pacemakers in Canada that are capable of ICD or CRT function. But that's changing. So we'll talk about that later. And they can be interrogated and reprogrammed non-invasively, so through radiofrequency current or ECG surface electrodes. They are implanted percutaneously through the femoral vein. They use a very, very large catheter, 23 French. And within 2 to 3 months, they can be epithelialized. Intraprocedural complications, some of them are similar to traditional pacemakers, and there's some new ones. Lead dislodgement, transient arrhythmias, access site bleeding, especially with such a large catheter, and then pericardial fusion, tamponade, perforation have all been documented. In terms of extraction, so some of the leadless pacemakers have extraction devices where they can be kind of unscrewed from the myocardium. Short-term research shows that there's good safety profile to this, but the other option is that because they're so small, they only take up about 1 to 2% of the RV wall volume. And so there have been many cases where they just leave the leadless pacemaker implanted, turn it off, and just implant a second one. And that's been done up to 3 times so far. So there's a patient out there with 3 leadless pacemakers with only one of them functioning. So long-term research is kind of needed to know which approach is best for which device and after how long. These are the devices. So these are the two main devices available in Canada. There have been others in the past that have been discontinued, and there are others in development that we'll talk about, but these are the two currently available. The left is the Micra. It's very small, and there are two types, but they look essentially the same. They have these tines, which are those kind of hooks on the top, and that's how it implants into the myocardium. And then slightly longer than that is the Avere, and there's two types of Avere. Leadless pacemakers. The one on I guess the middle, the shorter of the two is the atrial leadless pacemaker, and the one on the right is the ventricular leadless pacemaker. They both have kind of this helix, almost like a spring on the top, and that's how they kind of screw into the myocardium. So that's the extraction method that they've designed. So starting with the Micra. Again, there's two types. The first is the VR or the VR2. The VR2 is just an updated version, mainly with a longer battery life. But it was first released in 2016. It is implanted into the RV, and as such, it can only sense and pace the right ventricle, so VVI. Battery life of 12 or 17 years, depending on if it's VR or VR2. And then because it cannot sense the atrium, there's no AV synchrony, so as well as no AV pacing. The target population for this would be patients that don't depend on that atrial kick or the AV synchrony, so patients with permanent AFib as well as AV block. So pretty limited patient population, but then they released the AV or the AV2. So AV, you can guess that it involves the atria. So it was released in 2020. It's again a single leadless pacemaker in the right ventricle, and it uses an accelerometer to detect atrial movement. So it can kind of sense the atrial activity, not through detecting electrical activity, but it actually detects the motion. And so I can do a VVI mode, or it can dual sense, so VDD mode. The battery life slightly less, 11 or 16 years, depending on the version. And then again, it has no atrial pacing ability, but it can sense, and it allows AV synchrony. What I really wanted to emphasize about the Micra is that there is no magnet response whatsoever. So it's not like there's a magnet response that can be turned on. There's just no magnet response, so they need to be reprogrammed to be in asynchronous mode. So on the left, you can see where the Micra is implanted, so kind of in the septal wall of the right ventricle. And then on the right, you can see the chest X-ray. So a few differences between the Micra and Avere. On chest X-ray, the Micra, like I said, it's a bit shorter. It's more radio opaque. And then the Avere, you can see that fixation helix. Again, this is the Micra, so you don't see that here. And when you see the Avere, it'll make a little bit more sense, but they can be distinguished on chest X-ray, which is again important because the Micra is not magnet responsive, but the Avere, as we'll get to, does respond to a magnet. So the Avere is kind of a family of pacemakers. So there's the AR or AR2 and the VR. As you can guess, the AR is for atrial and the VR is for ventricle. The AR was released in 2022. It's implanted in the right atrium. It can only sense and pace the right atrium. Battery's life is about 12 years, slightly longer for the new version, the AR2. There's no ventricular pacing. And with all the Avere devices, they have that kind of screw-in mechanism like we talked about, and they all respond to a magnet by converting to an asynchronous mode. The Avere VR, like I said, it's implanted into the right ventricle. It paces and senses the right ventricle, lasts 16 to 19 years, no atrial pacing. And what's really cool is that these two devices can connect to each other wirelessly to essentially form a dual sense, dual paced pacemaker. So they can send signals to each other to coordinate activity. Unfortunately, this takes kind of a big hit on their battery life. So almost a 50% reduction in battery life because of that wireless communication. But the cool thing is they have developed modes that will either switch from a DDD mode to an AAI plus VVI mode, depending on what's required by the heart. So you can save battery life that way by being in the AAI and VVI modes rather than continually talking to each other. So again, this is the location of implantation in the RA, kind of by the atrial appendage, and then in the RV on the septal wall. And I don't know if it's super easy to see the chest X-ray there, but it is longer. It's more transparent on X-ray, less radio opaque. And the one end you can kind of see the fixation helix, especially if we were to zoom in there a bit more. So kind of hard to tell, but again, if you were to see two leadless pacemakers, you could be pretty confident it's an Avere and that it would be magnet responsive. Leadless pacemakers, as expected, because we've removed those transvenous leads, they have a better safety profile. So overall, the complication rate is about 4.5% compared to 8% in transvenous pacemakers within 5 years of implantation. They also have a lower rate of infections, as expected. They also have a lower rate of heart failure-related hospitalizations. And because there's no lead going through the tricuspid valve, they have lower rates of tricuspid regurgitation. There are certain complications that have been completely removed, those related to the leads, like lead fracture, disconnection, malfunction, those related to the generator pocket, like a pocket hematoma, and then pneumothorax, venous stenosis, and obstruction have all been essentially eliminated. And then there's also been fewer system revisions. So that means people who receive these leadless pacemakers require replacements or extractions less frequently. So about half as much as the transvenous pacemaker populations. And the reason for that, I think, is mainly due to infection. So the transvenous pacemakers are often removed due to endocarditis or sepsis or whatever it might be, whereas the leadless pacemakers are endothelialized and can remain. There are limitations. So the one big risk is cardiac perforation. So as you can imagine, implanting a leadless pacemaker into the myocardium comes with, they found about a 1.5 to 1.9% chance of perforation, leading to pericardial fusion, tamponade, and occasionally death. And then there's this new complication of femoral vascular hematoma. And in the transvenous pacemaker populations, the rate of cardiac perforation is much lower, 0.1 to 0.8%. Interestingly, in more recent research, now that providers are more familiar with implanting the leadless pacemakers, that rate is actually quite similar. So it has come down, but something to note. The other interesting point is that the mortality is the same at 5 years, regardless of the complication rate. So there's no difference in mortality. And then the last big limitation is that these are so new. There's very little or no long-term data beyond 5 years or so in terms of complications, in terms of the best way to extract or turn off these devices. So time will tell how they function long term. In terms of the target population for leadless pacemakers, because of the improved safety and the lower risk of complications. It's actually more of a discussion on what would exclude someone from a leadless pacemaker. So we try to get patients leadless pacemakers if possible. But there are certain populations that really benefit from a leadless pacemaker. Those would be those with an infection risk, so diabetes, those on immunosuppressive therapy, dialysis patients, and then those with limited vascular access. Again, dialysis or end-stage renal disease, prior burn injury, chemo or radiotherapy. Those with tricuspid valve disease, where a transvenous pacemaker would be contraindicated. So if they have a biological valve, they can have a leadless pacemaker. And then those with a bleeding risk would also benefit. Specific to us, so these are kind of in addition to the regular traditional pacemaker anesthetic considerations. So these are new and specific to leadless pacemakers. The first being that there is no implantation scar. And so if a patient comes in overnight, they're unresponsive, there's nothing on the chart, a pacemaker could potentially go unnoticed. The second is the variable response to magnet. So in transvenous pacemakers, almost universally, a magnet will cause conversion to asynchronous mode. Whereas in leadless pacemakers, the micra, as we mentioned a few times, the micra does not respond to a magnet. And in addition, there's a greater distance between the leadless pacemaker and the magnet. And so, especially with patients with higher BMI, the magnet response can be less sensitive. So the manufacturers sometimes advise the placement of two magnets, so a stronger magnetic force, as well as sometimes it requires more specific placement. You can't just slap it on. The other consideration is that there aren't great tests in terms of the sensitivity to EMI, whether it's more or less sensitive compared to traditional pacemakers. So more research needs to be done there. And then the very last consideration is the potential for embolization, especially with the right atrial leads. If you're doing any kind of right heart procedures, right heart cath, ECMO, even central line, and then CPR, all of those have the potential to dislodge the lead, especially in the first few months after implantation. So definitely caution there. I wanted to throw this resource out. It is designed by the American Society of Anesthesiologists. It's new as of 2024, and it is designed as a kind of a pocket guide, quick reference for the middle of the night when you just need to know how to manage a CIED intraoperatively. It's 12 pages, mainly flowcharts like this, and it takes you through leadless pacemakers, subcutaneous ICDs. It kind of has everything you need to know. In terms of leadless pacemakers, so again, it's very similar management to transvenous or traditional pacemakers, but the main difference is that, again, with the Micra, you need to reprogram the device. And in emergent surgery where reprogramming is not possible, then you just need to be cautious with electrocautery, have pads and magnet available. And then with the Avere, you can place a magnet as you would for a traditional pacemaker. So I also want to touch on subcutaneous ICDs. It's not the focus of this topic, but they, I think, in the future will become kind of inseparable from leadless pacemakers. Their purpose is, again, to avoid many of those lead and intracardiac associated complications. Again, similar to the complications that the leadless pacemaker is trying to avoid. So cardiac perforation, tamponade, pneumo, lead fracture and malfunction, tricuspid valve dysfunction, infection, and venous thrombosis and obstruction. So basically, subcutaneous ICD is a generator that's implanted, obviously, subcutaneously in the kind of the left thorax mid-axillary line. It has a single lead that travels extravascularly to the sternum and travels, it's either implanted parasternally or substernally. It requires a higher voltage compared to traditional ICDs because of that greater distance to the heart. And the main limitations is that these subcutaneous ICDs, I know before I said ICDs always have pacing. This is the one exception. So they have no long-term pacing. They'll pace for about 30 seconds after shocking, and that's it. They have no ATP function, so they will just shock, and that's it. And then they are also more sensitive to EMI. So our kind of traditional rule of monopolar cautery above the umbilicus is different. So with subcutaneous ICDs, we're kind of advised that the inguinal ligament is the safe zone. So everything below the inguinal ligament. The other thing to know, especially for us, is that there's a higher risk of inappropriate shocks, again, because of that greater distance, and that can cause decreased sensitivity to interpreting heart rhythm. And the other thing is there's a risk of shocking bystanders. So if you are contacting the patient, similar to external lead defibrillation, there's a risk of that shock, and actually a case report of an anesthesiologist being shocked by a subcutaneous ICD because they were touching the patient. So something to keep in mind. This is what the devices look like. So we'll talk a bit more about them. The brown is the emblem, and the silver is the Aurora, which was just released. So like I said, they're a generator with a single lead, and that lead travels to the sternum. In the emblem, it travels parasternally, and in the Aurora, it goes substernal, so closer to the heart. So the emblem was released in 2015. 2015. It has a very large generator, about double the size of a traditional pacemaker generator, and it only functions to defibrillate. It paces for about 30 seconds, but there's no long-term pacing. The battery lasts 8 to 7 years, and the magnet will disable anti-tachyarrhythmia therapy. The Aurora by Medtronic was just released. Its main advantage is that the lead is substernal rather than parasternal. So by placing the lead closer to the heart, it's able to use a smaller amount of energy to shock. And so because of that, the generator's half the size. The battery doesn't have to be as big. And the battery actually lasts longer, 11.7 years. The other advantage is that it has anti-tachycardia pacing. So you can avoid having to shock the patient if you're able to break the attack with anti-tachycardia pacing. And again, it is magnet responsive. This is what they look like on chest X-ray. The left image, you can see the generator is much bigger. It has a straight lead next to the sternum. And you can see the shocking coil there. So we know that this is the emblem. And then on the right side, you can see a much smaller generator with kind of a wavy lead under the sternum. And so we know that's the Aurora with the substernal shocking lead. In terms of the future, so really it seems like the way research and development is going is with kind of a modular system. So because all these devices are not transvenous, they are kind of outside of the venous system, and they can communicate with each other wirelessly. We are able to kind of add devices as the patient's needs evolve. So we can create a more catered and tailored approach to the patient. I mentioned the emblem before, so that's the subcutaneous ICD by Boston Scientific. Boston Scientific is currently designing and kind of in the final stages of developing this leadless pacemaker called Empower. So Empower will wirelessly communicate with emblem, and that will allow for it to have ATP function as well as pacing after, long-term pacing after shocking. So it will kind of by combining the two, it will kind of mitigate the limitations of each individually. And it's able to function very similar to a traditional ICD device. So again, it's in development, but I think it's coming, relatively soon. The other thing I really wanted to talk about was the YCRT device. So this is also in development. It is approved by FDA in 2025, but not yet. I don't think it's approved by Health Canada. But basically what it is a alternative to our current CRT devices. So our current CRT devices are very limited due to the fact that we implant a lead in the coronary sinus, and depending on the anatomy of the heart and the LV, conduction from the coronary sinus to the LV to stimulate contraction can be pretty variable, and about 30 to 40% of CRT devices don't function in patients. They don't respond and don't have an improvement in their ejection fraction. So the CRT device is basically an electrode that's implanted, again, percutaneously. They go through the femoral artery, up through the aorta, and into the LV. And they implant this electrode into the myocardium of the LV. And then they implant a subcutaneous transmitter, again, kind of on the left mid-axillary line. Yeah, so basically this transmitter generates ultrasound waves that stimulates the electrode, or sorry, the electrode transforms that ultrasound energy into electrical energy to stimulate contraction of the left ventricle. So it's a way to stimulate LV contraction without having to go to the coronary sinus. It's designed to be functional with any traditional or leadless pacemaker that's available. So it can be combined with any currently used pacemaker. The battery life is very short. Again, this kind of depends on usage, but around 2 to 4 years. And then the main limitations is it has a very, very high risk of complications. So 17, almost 18% had complications. 1.3% resulted in death. So a very high complication rate, as you'd imagine, for going through the left side of the heart. But again, it's very, very early in development, and that might improve significantly. So right now, it's really only approved for patients that are eligible for CRT, who would benefit from CRT, but who have a contraindication to CRT therapy, or who have not responded to CRT therapy. But yeah, I really think the way our cardiac electronic devices are going is kind of this modular approach where patients can have, if they need a right atrial leadless pacemaker, they can have that. If they develop AV block, they can have, at that time, RV leadless pacemaker. If they develop a need for an ICD, they can have a subcutaneous ICD implanted, and so on. So again, kind of a more tailored approach, but again, all stemming from the leadless pacemaker and the non-transvenous kind of device approach. So that is kind of all I have for you. That's most of what I could find. Thank you very much for your attention. And if there are any questions, clarifications, if you want to access any of the resources, feel free to email me. Or if you have any questions now, I'd be happy to answer them. But thank you very much.
Very much. I just check before taking any questions. Do we have Robert in the room? Our medical student. I'm not sure if there's been a slight crosswire about the presentation this morning. Okay, does anyone have any questions for Dr. Schwartz about the leadless pacemakers?
Yeah. Yeah, so for the people on Zoom, the question was for patients who have AFib that receive a leadless pacemaker, is there additional anticoagulation indicated? Is that kind of yeah? So the leadless pacemakers do not have an additional need for anticoagulation, whether they have AFib or not. So if they have AFib, they would have the kind of the traditional AFib anticoagulation. And if they have no anticoagulation, then other than the perioperative um, anticoagulation that you'd receive for the procedure, there's no additional anticoagulation that would be needed. Yeah.
So, bigger. And normal ones, they just say don't put the over the generator, obviously that's not possible in the heart. Do they have recommendations for if you electrocute this, what you do that?
If you, sorry, I missed the last part. Yeah, so definitely if you use external defibrillation on a leadless pacemaker, or for some reason an ICD, subcutaneous ICD is not functioning and you need to externally defibrillate, the device should be interrogated afterwards. I actually am not sure on the timeline for, I think it's as soon as possible within 1 month, but the devices need to be interrogated and they should have follow-up. Yeah. Yeah.
One is just for the residents. Most of us, if someone has a defibrillator and they're coming for surgery, we're happy to turn it off. You can't do that on the oral device. You can turn it off only after you put the defibrillator back on. So you have to be in the operating. It's just one of those things. Maybe hasn't gone on in 5 years, you still have to do it. And certainly it's a good goal that. What we also have now for the pacemakers is your pacemaker at the right side will always give you a bundle branch block. And so now what they do is they have a longer electrode, and they actually, it's a little bit of time, but they keep screwing in and going here, there, and actually looking at the ORS. So they get a better, it's called a left bundle lead. And so instead of the ventricle doing the hula on echo, it actually contracts better. And the other thing is that be careful with defibrillators because number one, a lot of people are stupid. They don't know they have one. And well, I've had people come in, oh, I've never had surgery. You take them off, they got the big zipper down their front. And but I had a guy the other day that was really quite interesting. He had a terrible EF. That's why they get a defibrillator. But in so little myocardium, his VT would never reach a threshold for the defibrillator to go on. So every once in a while, you'll have a defibrillator and you'll see this kind of crazy VT. And why is it going off? Because it hasn't reached the threshold.
Yeah, so for those on Zoom, we just had a comment, a few really, really good points. The first being that you should always have pads on when you disable or change the mode of pacemaker. The second being that, or I guess one of them being that ICDs occasionally don't have thresholds that are too high to initiate anti-tachyarrhythmia therapy. And so they won't defibrillate or they won't initiate ATP. And so the patient will be in this kind of weird in-between rhythm where they're not being shocked, but they're also not at an appropriate rhythm. So that's something to be aware of. And then the last one, you might need to remind me.
They do left bundle lead.
Right.
So that you get a non-bundle branch block with your pacemaker.
Right.
A lot of these people, if you don't have avian dysfunction, that's one thing. But a lot of people who get a pacemaker also have LV dysfunction. Right.
Yeah, so the last point was for those on Zoom that they can implant leads kind of at the left bundle in the along the septum. And so by doing that, it's not CRT, but it's almost like this. It has an improved synchronized ventricular contraction where you don't have complete dysynchrony of your ventricles, but you're able to contract both ventricles at a much more similar timing. Yeah.
So going back up to the maybe phone.
Thank you.
Just one question, two questions. Where did you put five?
Yeah, so the magnet for leadless pacemakers. So if it is magnet responsive, like the Avir, then you can place the magnet. Again, it would be over the same location, so kind of like directly over top of the heart. Again, sometimes it needs an additional magnet, depending on the BMI of the patient. And you should see a change in rate, so you know that you've appropriately placed the magnet. They should always be on a monitor when you place the magnet, and you should see that the heart rate changes to a very specific rate. Most of them are around 80 to 100 beats per minute. Some start higher and then will slowly decrease to a constant rate within about 10 seconds, depending on the battery life that's remaining in the device. So that's kind of your confirmation that you have appropriately converted to an asynchronous mode. But again, the magnet placement can be more specific for the leadless pacemakers, and especially the subcutaneous ICDs. The magnet, as you can imagine, would be harder to place kind of on their side, and then also requires more specific placement. So EP should be contacted for subcutaneous ICDs if you're planning to place a magnet, just because that magnet placement can be pretty specific. I guess just a question for the room. Has anyone had a patient with a leadless pacemaker? Yeah, there's one. Yeah. And
Put them in.
putting them in. Fair enough. Fair enough. And any have you noticed like very significantly higher complication rate or?
Oh, well, and quadros. It's like, but.
Fair enough.
I mean, it's more involved general anesthetics. I think relatively big device compared to, transvenous possibly can only do it at the sedation of local anesthetic, but for these leadless, for the subcutaneous.
Yeah.
So depending on where you end up working, you might doing them or you might just.
Okay. Yeah.
We have a comment online just asking if you can put the slide back to the flow diagrams for what to do with the peri-op.
So is this for leadless?
Yes, for leadless. And then I had a question which you might have already covered.
Yeah.
If I have somebody with a pacemaker and I want to quickly assess what their dependency is, then I'm looking for big pacing spikes, and it's really obvious if the patient's dependent on it. Do you still get that with a leadless pacemaker if it's a smaller, or you still can see it on an ECG?
Yeah, so you should still be able to see them on an ECG. It can be a lot more subtle. So the spikes might be smaller, but for sure on a 12 lead, and usually on the monitor you can see as well the pacing spikes. And again, that should all be recorded if you have the patient's chart available. Pacemaker dependency will always be on the last interrogation, but if that's not available, yeah, definitely do a 12 lead if you can, and you should see those pacing spikes, but they might be a bit more subtle.
Okay, any other questions from the room? I think there's nothing else on the chat, so all that's left to say is thank you very much.
Thank you. Thanks so much.
For